And today we plan to do a MitraClip case for you.
Patient is a 76-year-old female patient. She presented us with complaint of progressively increasing shortness of breath. In her past medical history, there was a tricuspid valvular annuloplasty operation on April 2022. Before that operation, a coronary angiography was performed, and this coronary angiography showed non-critical lesions on LAD and CX, and also total occluded RCA. But on myocardial perfusion scintigraphy, there was no viability or ischemia on inferior posterior walls. For this is why a medical follow-up was planned for her coronary artery disease. The symptoms of the patient were relieved after tricuspid operation, but especially in the last few months, complaint of dyspnea started again, and it has been progressively increased.
Okay, thank you, Ahmet. So now I'd like to ask you, Özge, because now we have real-time image, of course, and let's hear from Özge. And I really...
This is the biplanar view, and you can appreciate the 3 and even 4 different jets of mitral regurgitation here. And here, of course, the blood pressure is also very important because at the beginning, and even during these previous TOE images, we had a blood pressure of 110. And we calculated also the regurgitant volume area and this area, EROA and regurgitant volume. You can see here, EROA is consistent with severe mitral regurgitation, functional one, and the regurgitant volume is also. And vena contracta was also like 0.7, which is also consistent with severe. And we have also enlarged LV and enlarged LA. And also flow reversal of pulmonary flow here and here as well. So we decided that this is a moderate to severe mitral regurgitation, and the symptoms are also consistent with severe mitral regurgitation. So we decided to go with a MitraClip.
That's fantastic. One thing, could we see X-plane through the valve?
Yes.
Thank you. So, in summary, we've got secondary MR due to a combination of atrial and a degree of ventricular dilatation. We can see that the annulus is enlarged. We can see that there is limited coaptation of the mitral leaflets. And so, I mean, the leaflets basically look normal, thin, healthy leaflets. They just look stretched apart. Is that your analysis?
Yes.
Could you explain where the needle is?
Yeah, okay.
Yes,
show me short axis, show me short axis now, because here I'm okay, I believe. Yes. Let me show you short axis.
Yes. I think it's posterior, you know.
Yeah, he's also not bad.
Not
what
bad.
do you think? I can go a little bit more posterior, but I think it's
it
not bad.
Okay, I think.
Ömer, good afternoon. It's Mohamed here.
Hello,
Thank you for taking part and doing this. It's fantastic you do it live. The rate limiting step is really the transeptal puncture. And I was going to ask you, which device are you going to use, MitraClip or the basket?
No, I will show you now.
We will use MitraClip.
It's around 3.78.
I think this is good for me.
Okay? Otherwise it will just fly off.
We did the puncture.
Yeah, I am in now.
Fraction, because initially they presented with tricuspid regurgitation, which has been repaired, and now has developed mitral regurgitation. And is there an argument that you would aggressively treat?
So this is now our left atrial pressure, which is 25, 26. Yes, yeah. So, and now we have the clip. This is XTW. Okay, now I think I'm close to mitral valve. Let's see. Can you show me, please?
So Ömer, can you tell us what position you want to have?
Yeah, so we will a little bit posterior. We will come back to anterior now. We just like to see bicameral view here.
We are very medial.
Huh?
Medial.
We are too medial. Yeah, I like to keep the angle, so I just pull my
medial,
lateral, a little bit. Yeah, okay.
Posterior, anterior.
Yeah.
Sometimes 3D is very helpful here. This looks better.
I can show a 3D view.
No.
And now this jiggly movement really is what we need is the clip to be orientated 12 o'clock, 6 o'clock on the annular plane. So the annular plane.
Oh, as you see, I'm too close to mitral valve, and then I crossed it. So it would be better, maybe more, high puncture, I would say. Anyway.
So normally, I mean, I think you've actually got away with this. You've bypassed about 50% of the problem, but normally you would spend some time above the mitral valve, orientating the clip, opening it to make sure that you were perpendicular.
Exactly.
But actually, by serendipity or skill, you're in actually a good position.
So this is XTW, so we have to, I think, to be perfect for perpendicular, because otherwise we might have a problem. It's a big clip. We have to be perfectly, I think, perpendicular here. So we implanted one XTY-W.
Let's see.
Let me show you.
This was the first one?
This was the first grasp.
Well, we were unhappy.
So we will have some, regurgitation through middle side. So there was indentation that place anyway, but we like to have, to go a little bit more medial. So
we changed.
We changed the position a little bit to more medial, and then we grasp again.
This was the grasping.
Yeah,
the second one.
We have apnea during grasping, and
no medial.
Now we don't have that much medial regurgitation now. We have lateral, which is okay. So we are happy.
So the initial position, you split the jet.
Yes.
So you released and you moved more medial.
Yes, exactly.
To take in the medial leak. So we can see that you're the medial side of center here on the 3D.
Yeah. So now we plan to implant another one. So
has there been any change in the hemodynamics or LA pressure?
It was 25
yes,
before.
At the beginning
dropped
it was
to 10. So, we thought that one clip will be not enough, right? So we thought that we need to implant two clip here. So we thought if we implant another one to the lateral, the medial jet will be obviously much more. So which we could do anything about the medial one. So we thought that it's better to move a little bit medial to reduce the regurgitation that side and implant another one to next to first clip. So
it's easier to put a second clip lateral to the first.
Oh yes, of course. Yes,
we
of
always
course.
start from the medial part.
Yeah, exactly. Yeah. So we have another XTY-W here, and I'm inserting.
What's the mean gradient now?
2.
We'll just
2.
Yes, we just finished the case and we closed the groin, and let me show us the second clip and final results, Özge. I think position of the two clip is nice on the screen. They're parallel and not that close each other. We have a mild regurgitation, and left atrial pressure was 9.
The flow can make us confused, and you can see the pulmonary vein flow, and there is no more flow reversal. S is bigger than D.
Yes.
So it is consistent with mild mitral regurgitation.
According to pulmonary vein flow, it's mild MR now.
Yeah, because with color, there is mostly crisscross effect, and this may make us confused. So color is not that much important at the moment. More concrete findings such as pulmonary vein flow and LA pressure is more important.
I totally agree. The patient is almost certainly going to feel a lot better. The hemodynamics are better and the pulmonary vein flow is now normal. Where is the residual leak? Is it between the clips?
No, actually,
it's a little bit medial.
It is more medial, actually.
More medial. Still, we have some more.
It is just the medial one.
Here, yeah.
Just the medial one.
Just the medial, we have some.
And the residual, the mean gradient is 3.
Mean gradient, yeah, it's 3, yeah.
It would be very difficult to get any more in there. And the transeptal, you just left, you didn't have to do anything to that, didn't have to close the septum?
No, we didn't. No. Normally we didn't do it. If we have, you know,
desaturation.
desaturation or, you know, high pulmonary artery pressure, then we may consider it, but routinely no.
Well, I think we're just going to say congratulations, because you knocked that quite challenging case off pretty quickly, and although there are bits of colour, and that's very common, the patient is going to get better based on pulmonary vein flow and LA pressure. So congratulations to you and all of your team, particularly your echocardiographer colleague.
Thank you so much.
You've done a great job, and well done.